Welcome to this Step 2 clinical knowledge review on spine disorders test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for spine disorders and teach you strategies to pick the right answer quickly and confidently. The goal here is not to reteach the entire topic. Instead, we want to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the musculoskeletal and neurology sections of first aid and your question bank before or alongside this video. Let us jump right in. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for spine disorders on the boards. Second, we will go through test-taking strategies for low back pain evaluation, Cauda equina syndrome, spinal stenosis, and cervical radiculopathy questions. Third, we will master the next best step question format that the exam loves to use for spine cases. We will also walk through several practice questions with full answer explanations. Before we start, make sure you have reviewed the musculoskeletal and neurology chapters in first aid and your question bank. This video is about applying that knowledge strategically, not learning it from scratch. Our first strategy is what I call the mechanical versus emergent split. When you see a low back pain question, your first job is to sort the patient into one of two buckets. On the left side, we have mechanical low back pain. These patients are typically under 50 years old. Their pain improves with rest. They have no neurological deficits, and they have reproducible musculoskeletal tenderness on exam. The boards want you to recognize that these patients do not need imaging or aggressive workup. On the right side, we have the emergent red flags. Look for saddle anesthesia, urinary retention, bilateral leg weakness, fever with back pain, or progressive neurological deficits. When you see any of these, the answer shifts to emergent imaging with magnetic resonance imaging. This is the single most important distinction the boards test in spine questions. Master this split, and you will get the majority of low back pain questions right. Strategy 2 is about differentiating spinal stenosis from disc herniation. These two conditions come up constantly, and the boards love to present them side by side. Spinal stenosis presents in an older patient with bilateral leg pain and heaviness that gets worse with walking and standing. The key feature is that symptoms improve with sitting or leaning forward. The shopping cart sign is a classic board buzzword. The patient feels better leaning on a shopping cart because flexion opens up the spinal canal. Always compare neurogenic claudication from stenosis with vascular claudication from peripheral arterial disease. Vascular claudication improves with rest in any position. Disc herniation is different. It presents in a younger patient with unilateral radicular leg pain that follows a specific dermatomal pattern. The pain gets worse with sitting, bending, or the Valsalva maneuver. A positive straight leg raise test is the key physical exam finding. The most commonly tested levels are L4 to L5 and L5 to S1. The boards love asking which nerve root matches which motor or sensory deficit, so know those dermatome maps. Let us go through the three most important stem patterns you need to recognize. First, Cauda equina syndrome. The patient presents with acute low back pain plus saddle anesthesia, urinary retention or incontinence, and bilateral lower extremity weakness. This is a surgical emergency, and the next step is always emergent magnetic resonance imaging of the spine. Second, spinal stenosis. Look for an older patient with bilateral leg pain that worsens with prolonged walking and extension. Symptoms improve with flexion, sitting, or leaning forward. The shopping cart sign is your clue. Diagnosis is confirmed with magnetic resonance imaging. Third, cervical radiculopathy. The patient has neck pain radiating to the arm in a dermatomal pattern with numbness or weakness. The Sperling test reproduces the symptoms. The question will usually give you enough information to figure out which nerve root is affected based on the motor and sensory findings. Memorize these three patterns and you will recognize them instantly on exam day. Here is our first practice question. A 35-year-old man presents with acute low back pain after lifting a heavy object. He reports numbness in the groin area, difficulty urinating for the past 6 hours, and weakness in both legs. On exam, he has decreased rectal tone and absent ankle reflexes bilaterally. What is the most appropriate next step in management? Take a moment to think through this before we go to the answer. Look at the answer choices. A is lumbar spine radiograph. B is oral non-steroidal anti-inflammatory drugs and follow up in 2 weeks. C is emergent magnetic resonance imaging of the lumbar spine, and D is electromyography and nerve conduction studies. What pattern do you recognize here? Let us walk through this answer step by step. Step 1. Spot the pattern. We have acute back pain, saddle anesthesia, which is the groin numbness, urinary retention, bilateral weakness, and decreased rectal tone. This is a textbook Cauda equina syndrome presentation. The combination of bladder dysfunction and saddle anesthesia is the highest yield clue. Step 2. Apply the rule. Cauda equina syndrome is a surgical emergency. The next step is always emergent magnetic resonance imaging to confirm the diagnosis before surgical decompression. You should never delay imaging with conservative management when these red flags are present. Step 3. Eliminate the wrong answers. Answer A, lumbar spine radiograph, is wrong because plain films cannot show soft tissue compression and will miss disc herniation. Answer B, conservative management is never appropriate when there are signs of cauda equina. Answer D, electromyography is a chronic workup tool and not for emergencies. The correct answer is C, emergent magnetic resonance imaging of the lumbar spine. Here is our second practice question. A 68-year-old woman presents with a 6-month history of bilateral leg heaviness and pain that worsens when she walks more than 2 blocks. She reports that the symptoms go away when she sits down or leans forward on her shopping cart. She has a normal vascular exam with palpable pedal pulses. What is the most likely diagnosis? Look at the choices. A is peripheral arterial disease. B is lumbar spinal stenosis. C is lumbar disc herniation. And D is diabetic peripheral neuropathy. Think about what clues in the stem help you narrow this down. Let us break this one down. Read the question carefully first. This describes classic neurogenic claudication, bilateral leg pain with walking that improves specifically with flexion. The shopping cart sign is a board favorite and should immediately make you think spinal stenosis. The normal pedal pulses are critical here because they help rule out peripheral arterial disease. Vascular claudication causes similar symptoms with walking, but it improves with rest in any position, not specifically with flexion. Now let us look at why spinal stenosis is the answer and the others are wrong. Disc herniation usually causes unilateral radicular pain in a younger patient, not bilateral symptoms in someone who is 68. Diabetic neuropathy causes symmetric stocking glove sensory loss and does not cause positional leg pain that changes with walking or sitting. Peripheral arterial disease would show diminished or absent pedal pulses, which this patient does not have. The correct answer is B, lumbar spinal stenosis. Now let us talk about cervical radiculopathy. The clinical presentation is neck pain radiating to the upper extremity in a dermatomal distribution. The key physical exam finding is the Spurling test, where you extend and laterally rotate the neck toward the affected side while applying axial compression. This reproduces the radicular symptoms. You need to know the key dermatomes for the boards. C5 affects the deltoid and the lateral arm. C6 affects the biceps and the lateral forearm with the thumb. C7 affects the triceps and the middle finger. C8 affects the hand intrinsic muscles. For management, most cervical radiculopathy resolves with conservative treatment, including non-steroidal anti-inflammatory drugs, physical therapy, and activity modification over 6 to 12 weeks. Magnetic resonance imaging is indicated for persistent symptoms or progressive neurological deficits. Surgery is reserved for patients with signs of myelopathy or failure of conservative treatment. The boards frequently test when to image versus when to treat conservatively. If there are no red flags, conservative management is almost always the right first step. Here is our third practice question. A 45-year-old man presents with 3 weeks of neck pain radiating to his right arm, along the lateral forearm and into his thumb. He has a decreased biceps reflex on the right. The Spurling test reproduces the arm pain. He has no difficulty with gait or bowel or bladder function. What is the most appropriate next step in management? The choices are A, emergent magnetic resonance imaging of the cervical spine, B, non-steroidal anti-inflammatory drugs and physical therapy referral, C, immediate surgical referral for anterior cervical discectomy, and D, electromyography and nerve conduction studies. Think carefully about what the question is really asking. Let us walk through this one. First, spot the classic pattern. We have neck pain with radicular symptoms following a dermatomal pattern, a decreased biceps reflex, and a positive Spurling test. The lateral forearm and thumb distribution points to the C6 nerve root. This is straightforward cervical radiculopathy. Now here is the key distinction. The question specifically tells you there are no myelopathy signs, no gait instability, no bowel or bladder dysfunction. Without those red flags, this is managed conservatively first. Emergent imaging is reserved for cases with myelopathy signs or Cauda equina symptoms. Immediate surgery is premature without trying conservative therapy first. Electromyography is a tool used later if symptoms persist beyond 6 weeks and you need to confirm nerve involvement. The correct answer is B, non-steroidal anti-inflammatory drugs and physical therapy referral. The takeaway here is that the boards want you to resist the urge to over-investigate when the clinical picture is straightforward and there are no red flags. Here is an important test-taking pearl about imaging decision rules. On the left, we have when not to image. Acute low back pain in patients under 50 with no red flags does not require imaging. Conservative management with non-steroidal anti-inflammatory drugs and activity modification for 4 to 6 weeks is the right approach. The boards frequently test your ability to avoid unnecessary imaging. If you see a young, healthy patient with mechanical back pain and the answer choices include getting a scan, that is almost always a trap answer. On the right, we have when to image urgently. The red flags include saddle anesthesia, urinary retention, bilateral weakness, fever with back pain, history of cancer with new back pain, significant trauma, or progressive neurological deficits. If any of these are present in the question stem, the answer is emergent magnetic resonance imaging. This is one of the most high-yield distinctions on the entire exam. The boards want to see that you can tell the difference between benign mechanical pain and a surgical emergency. Master this framework, and you will feel confident answering any spine imaging question. That wraps up our review of spine disorders test-taking strategies for Step 2. To keep studying, review the musculoskeletal and neurology chapters in First Aid and your question bank. Focus on spine disorder presentations, imaging decision rules, and nerve root localization. Practice differentiating mechanical back pain from surgical emergencies until it becomes second nature. Visit roadmap-to-residency.com for expert tutors and residency advisors who can help you build a personalized study plan. Make sure to like this video and subscribe to the channel so you do not miss our other board review videos. Good luck on your exam, and we will see you in the next one.